managing the tubing with mobility, I don't know, kind of the basics.
Do you guys go through a suctioning competency? Are you
I know
supposed to suction?
At Waukesha Memorial, at their ICU, I feel like the nurses, not that they expect us, but like sometimes I feel like if they're not available or respiratory is not available and like we need to suction someone and there's not anyone else that we can go to, and like I have seen therapists like in that moment do it just because.
Orally or ET tube and trach?
Just orally,
Okay,
not E2.
okay, okay. Okay.
We have not had a recent competency for that. It might not be a bad thing to come out of this.
Okay.
Those of us who have been practicing for longer have probably had more opportunity to do suctioning on a regular basis, especially if you've been working in an acute rehab setting. You might have more opportunity to do it more frequently.
Okay.
So that certainly would be a conversation that I'm sure Maggie would welcome.
Sure. Yeah.
That's what it for me. How about you guys?
Yeah, kind of ditto to everything you said.
Okay.
Okay. Great. Now, are we working towards getting like patients up out of bed that are vent dependent, or we're not?
We recently had a patient in the Waukesha ICU that we were mobilizing. Well, it was a lift though, but I have
Okay.
occasionally moved patients on the vent with numerous people
Sure.
in the room.
And they were
obviously.
trached or orally? Okay.
But yes, there is ongoing early mobility.
Yeah, yeah, and I think that's great, and I think here you'll probably be able to get more, like if you are working with someone, we do have 2 RTs here most of the time now, so it'll be a lot easier for us to be able to get there and help you if you need it.
And they're really good at Waukesha too with like coordinating us.
Yeah.
That'd be good. Really appreciate you guys.
Yeah. Most of the time, if you just tell us when and where, we can make it happen. And like at Waukesha, sometimes there's like 10 vents running, you don't hear it's 1, 2, maybe 5, but usually not. So I won't be able to show too much because I don't have oxygen and air, but I'll start with the modes. So we'll get a lot of alarms right now, but I'll try to silence most of them. So this one across the top is spontaneous CPAP. That is the patient is breathing completely on their own. There's no set rate, there's no set pressure, there's no set volume. We do give them a little bit of PEEP and pressure support, and that's to overcome the resistance of their trach and all of this tubing. If they are trached, they'll be on a heated wire, so you might have some rain out, and to watch that it doesn't dump into the patient, but usually the therapist can just dump it back to the heater. So it's a quick fix, but usually the long-term patients that are trached will definitely be on a heated circuit system, which is like blue and white.
tubing.
Yep, exactly. So spontaneous or CPAP is great. They're usually on a step to really close to coming off the vent. That would be the next step, would then be coming off the vent for periods of time and then being on a trach collar or a cool aerosol trach collar. And that's just more for humidity and oxygen needs. If they're on a little bit more support, you'll probably see this pressure control SIMV or pressure control CMV. And with that, the patient has a set rate, a set volume or pressure. They'll probably be in volume. So you'll see that, and then modes will come across the top. So this VCAC is assist control with volume ventilation. So they have a set volume, they have a set rate, and set PEEP, but they can breathe above that as much as they would like, and every breath that they initiate over what we have set is completely supported. So they may be breathing 20 times a minute, but the vent might be set at 10, so that's like the bare minimum. And then the volumes are usually ordered based on their ideal body weight by the probably the pulmonologist or the intensivist on. A lot of patients are on lower tidal volumes for lung protective strategies. And the volumes and the rate is tweaked by their blood gases or chest x-ray. And then to answer your question about PEEP, PEEP stands for positive end expiratory pressure. That is the pressure that always is in your lungs. Me and you sitting here, we're probably at 2 to 3 centimeters of water pressure.
Okay.
When you're on the vent, I'd say a minimum of 5. As you have more atelectasis or trouble oxygenating, your PEEP will go up. So sometimes, most of the time, as your PEEP gets a little bit higher, you're probably a little more unstable.
Okay.
Not always, but most of the time. Like sometimes if you're just a big individual, sometimes you just need a little more PEEP naturally. So it's not a hard and fast rule, but as your PEEP goes up, it's usually because you're not oxygenating.
Okay.
And then that PEEP is just that air you can't get out, so it keeps your lungs open, keeps them from, yep, exactly. Sometimes as you go up on your PEEP, your blood pressure can come down, so things like that we look for as well. So if somebody's really unstable with their blood pressure, we might need to lower their PEEP and go up on their FiO2. So the FiO2 and the PEEP kind of go hand in hand with oxygenation. Does that make sense?
That does.
Mhm.
And then as you get better and you wean your FiO2, we'll bring our PEEP down. Usually to like 5 to 7, depending. And then once their oxygenation and FiO2, or their FiO2 and their PEEP come down, then we can kind of flip them to that CPAP and start them breathing on their own. And then hopefully their ventilation and CO2 remain stable. And then we can put them on CPAP. So those are the 2 big modes, is more of a assist control, or you're kind of on your own and we give you a little help. The pressure support that we set is usually, you can see it like 5 to 10, I would say, is like a good normal range. And that's just how much help you need to achieve good tidal volumes. So we'll get tidal volumes back here from the patient, and if they're very small, we might want to increase their pressure support and just give them a little more pressure. They're totally breathing on their own, they just need a little extra help to get their lungs and volume to where they need to be. Each settings are the same across the top, across the bottom. These are all set parameters, so this is what the physician has ordered or that we have titrated. And then anything up here is what the patient's doing. Yep. So you might see like high pressures or higher volumes as they're working with you guys, and that's fine. It's probably a good thing, because you will probably open them up working with them and getting them breathing heavier than this will do. If there was an emergency and they were desatting, there is an FiO2 increase button. It says O2 suction. You can hit that, and this will, it won't, but it would go up to 100% oxygen. The scary thing about that is don't leave the patient, because it silences the alarms, because it thinks you're gonna suction them, so if the patient were to become disconnected, it won't alarm right away. So you can cancel that by hitting the same button. It would stay gray had I have this hooked up, and then you would just hit it again to cancel it, or by that temp, hopefully we're there to help you. Worst case scenario, you can always take a patient off the vent and bathe them. Are you comfortable doing that, or not really? It's scary. Hopefully we're somewhere close by and we can respond, but some common signs of distress are just their oxygenation drops. They'll look like they can't breathe, they'll have that bluish color, they'll have that look of panic. Their respirations might drop or increase, heart rate may do both as well, drop or increase. But it's probably hard, because when you're working with them, they probably get a little tired and their heart rate goes up too. So if you know someone's a little more sensitive, feel free to always just say, hey, I'm gonna work with them, can you meet me there at X, and just be there until I get them going or something. I can't remember what your other question was. Is that it, trach? If it's a trach patient, they're usually much more stable. When we do get to that point where we up and move with them, we'll have to come and move the vent with you guys and kind of work together when we get that far, but it's exciting to see that we're moving in that direction, because some patients, just need a little more time to let their lungs heal, but the rest of them can be worked with, so like those types of patients would be really good to see them, like even just get up into the chair or something.
Right.
And now we do have those new beds, so that'll be nice to get
Mhm.
them like up in the chair position. The extension tubing is unfortunately, or the vent tubing isn't very long, but we can always maneuver the vent or move it closer or move it forward. That way the patient has room to like sit up into the chair or like get them into the chair. Anything else? You guys see?
I mean, I know we've had a couple patients in the past who we did, we have coordinated our efforts to make sure that we're both there at the same time. And it really goes nice having someone who can be dedicated to the vent.
Yeah, for sure, because and as they work with you guys, they're gonna sound off lots of alarms, so that can be intimidating too. Just if they
And I
take a
think
really
that's
big breath
The
or
biggest thing
something.
is like which alarms.
If you see this red one like this one's going, that's a high priority alarm. It gives the sound that you just heard. If this is yellow, it gives a little bit different of a bell, and that's a low priority alarm. It's just something's a little off, it's not like an emergency.
Because I do typically get the alarming like with activity.
Yeah,
So-
you might get like the low priority if they take maybe just a little bit too big of a breath or a little bit too low of a breath, or their minute volume's a little low. If they're like shallow breathing, you might get those kind of low priority alarms. If the patient becomes disconnected, you would get a high priority alarm. If the patient's peak airway pressures are very, very high, like they're working too hard and they might have a pneumothorax because the pressure is just way too high, you get a high priority alarm. So anything red is kind of a little more serious than the yellow. Sometimes they just cough and it sets that off too. And if it fixes itself, the patient fixed themselves, it's fine, but if it continues, then it's something a little more serious. Most of the time if the patient's disconnected, it's just a quick reconnect, and it's usually pretty obvious because you can hear the air coming from the vent circuit, but if they're on like CPAP and some minimal settings, you might not hear the vent air coming from the circuit, so it will say a disconnect. And this vent's very intuitive, it'll kind of give you an idea of what's going on. It might say airway obstruction with a question mark if they're coughing, or it might say patient disconnect if they're really disconnected. I might be able to get it if I don't have, or if like the screen is like this and you're getting nothing, you probably have a disconnect somewhere. There you go. It should say like patient disconnected across the top. I got these no O2 and no air supply alarm instead. Yeah. Questions? Or when you do have a patient and you just want a quick refresher, feel free to call us. We're always around.
Yeah, I don't know if there were any other questions from the Waukesha side. We didn't really get a printout of what was asked over there. So I don't know if there was, other things that they had come up with that they were curious. I think it's just a lot of basic, what are we looking for? What do we do when?
Sure, yeah. Or, I mean, worst case scenario, like if there is an emergency and you can see your patient's like blue
In
and
distress.
diuretic, you can touch and turn up the FiO2 and then just touch it again. Or the nurses do know how to adjust the FiO2 as
Right.
well. So that would be the quick fix if you are all alone.
This isn't about vent, but like working with someone on like vapotherm
Oh, sure.
or things like that. Like on there, like I'm not familiar with all the total settings, but I've had a couple.
Sure.
Of
The vapotherm is becoming very, very popular. So it has the green, red, and white. And I don't remember the color, but the flow is usually the first one off to, no, it's the FiO2, I believe, the first one to the left. And on the adult circuit, it's 21 to 100%, and that's how much oxygen that they're on. And then there's the liter flow. I don't know if I got that in the right order, but either one's on top. And the liter flow can go from 0 to 8 to 40,
Okay.
or 20 to 40. I can't remember, but it goes up to 40. And what happened, and then there's the temperature, and the temperature is just because there's so much flow, it needs to be heated and humidified to keep the patient comfortable. So the temperature is just whatever the patient can tolerate. So the higher flows just help wash out your CO2 instead of having like on that big BiPAP mask. It sounds really loud, and that's because the cannula bore is a lot smaller, so it's kind of like a garden hose. Like when you occlude half your garden hose, your water goes shooting out. It's a high velocity. So it's the same flow, but because there's a much more higher velocity, it can wash out the dead space. So you might see some patients on like BiPAP overnight or BiPAP here and there, and then like vapotherm to eat or maybe to do therapy with you guys, because then they can talk, they can drink, they can communicate with you when they're on the BiPAP. It's so hard to hear them under the mask. And then the BiPAP can cause some pressure injuries, especially on their bridge of their nose. So if they are on BiPAP, we like to give them breaks if we can. But yeah, the vapotherm's been really popular. You can give any amount of oxygen with any amount of flow, so it's kind of nice. Some patients need a little more flow for a little more support and CO2 washout, and some patients really just need a lot of oxygen, and then instead of having like the oxy mask or the BiPAP on, it's a nice break. A downfall for the vapotherm from a therapy standpoint is the circuit is not the easiest to deal with. It's a little heavy, I would say. It's not the and again, you have to be plugged into the wall or an oxygen or air source. So if the patient wanted to leave the room, we would need to have some tanks and try to get the vapotherm attached, but it has to be plugged in at all times, so you probably couldn't go very far. They do make a transport unit. We don't have one here, but I know Waukesha, I believe, has a transport vapotherm unit, so you could potentially walk someone around on that, because there's like a battery pack, and then there's air and oxygen tanks. So I'm pretty sure they have that. But the vapotherm is really popular.
Yeah, I just was in the ICU and I feel like I got a lot of my patients from.
Yeah. You know, I feel like if you need like even like 10 liters, you would probably benefit from the vapotherm, just to have that extra flow. And then if it's more like mucus plugging, sometimes the vapotherm with the heat and humidification kind of help thin secretions and get them easier to cough up. But the BiPAP kind of tends to dry people up. I mean, BiPAP's great though. You kind of need it.
So, go ahead.
No, actually you go.
So with pressure support, sometimes it'll be that they're on pressure support for weaning in terms of being extubated. So oftentimes I will like hold and let them just focus on breathing so that they can determine if the extubation is going to be good or not. If it's a day that they're just giving, because I've noticed sometimes in the chart they're just giving them some pressure support hours and then they kind of put them back on. Would you still, from your standpoint in terms of respiratory, would you still say activity when they're off of the pressure support?
Like to do activity off of the pressure support?
Yeah,
Or
so like when they're back onto their settings
Yeah.
versus doing it when they're on the pressure support?
I would say it's kind of patient dependent, but I almost would say do it when they're on their full support. That way their breathing doesn't tire them out, and then once they're back on their full support settings, if you worked with them, then they could use their calories and energy with you versus breathing. But I know you guys are only here certain time or like certain hours, so we could always rearrange our pressure support trials too. If it's, for 4 hours, we could do it. We could leave them on full support. You could work with them in the morning and then give them like a little break and then flip them to pressure support too. We could always work in the opposite. Sometimes we like to put them on pressure support before rounds, so we know kind of like where they're at when the doctors get there at 9. So then we can be like, oh yeah, they've been doing great on pressure support, X, Y, and Z, or no, they didn't do well at all. But it's good to know if they can tolerate therapy while they are on pressure support, because that might be a good indicator that they may or may not be ready to be extubated. Like if you can't do therapy and breathe, you might need another day, but.
Right. So maybe more conversations with RT as we're trying to schedule some of these, depending on what we're seeing
Yeah.
as far as documentation in the chart and what the plan might be.
Yeah, because sometimes they may be on pressure support like all day, and that's fine, then I guess just work with them on their pressure support settings, and then if they get tuckered out, then we can give them a break.
And that's more what I'm thinking, because it's like those ones where it's like, okay, it's been a few days and they've had these trials, but it's like no, and then we've missed therapy. So it's like trying to figure out the longer cases.
I just had a question pop in my head, like, why are some patients like on oxy masks, aero masks, nasal cannula, like what determines what they are given?
Sometimes, well, a little bit of both. Sometimes it's the patient. Sometimes they just physically feel better with having a mask on their face.
Or if they're like mouth breathers?
Yeah, but the oxy mask can go 1 to 15, and our new nasal cannulas, like the green ones, can go 1 to 15. So they'll give you the same amount of flow. The oxy mask has a little tab at the bottom of the circuit that tells you about what FiO2 they're getting. And it's probably about the same with the cannula too. So it kind of is dependent on the patient and their comfort level.
Now with the green tubes, are we not supposed to add a connector to them?
They come with extra long, so I would have to look.
Okay.
I forget,
Is
I
that
just
good?
looked this one up
Because
too.
I feel like with the green tubes that the nursing staff has said not to, but sometimes it still does not reach to the bathroom. So then we're still limited in mobility with that, so we bring in a carrier.
I have like, yeah.
The tank,
Yeah.
Thank you. I was like, two?
Yeah.
Yes.
I know we looked into having, I know in the past we said no extension tubing with the oxy mask. But we looked into that and we didn't get a good answer because it depends on like the flow meter and how much pressure it can handle. So we kind of hit a wall with that one with Biomed because I don't know what goes on behind the wall. But I think with the nasal cannula you might be able to, but I'll double check. I feel like the new ones came with long, but to your point, it might not be long enough in some of the rooms to get into the bathroom.
Yeah, the green ones do seem long
Yeah.
in comparison,
Mm-hmm.
and just depending on the layout of the room.
I don't think I've gotten into any bathrooms with the
Mm-mm.
green though.
No? Okay. Maybe they can then. I'm gonna assume they can, and I'll ask and do a little research.
I just want to make sure, and what I've kind of done with some of the nursing is put it on for my session, but then taken it off at the end, like they don't want it to be left on.
Oh, okay, that makes sense.
I don't know if that's okay though, it's more like, is it a flow problem, or is it just the length of the tube?
I think it won't be a flow problem unless they were on pretty high liter flows, like that 10 to 15 end. If they're on like 1.
Right, it's like the 3 or 4, like,
Yeah.
but if they're up that high, I'm probably not doing stuff in the bathroom, so
Mhm.
it's like more like that 6 or less range.
So the green is not necessarily an indicator that it's a high flow.
No, but it used to be, to
It
your
used
point.
to
It
be.
used to be. Now green is a one-stop shop that goes all the way
Okay.
up and all the way down. So it was a system-wide change. Instead of having 2 different cannulas, a low flow and a high flow, you just have the one.
Okay,
Okay.
So you
So that
shouldn't
may-
really see the white plastic cannulas unless it's like a home care patient and they came in with their own cannula in. Otherwise, all of the patients here will have that green one with the little ear guys that come with it. That all comes
well
with
that's,
it
I
now.
think that's helpful to know.
Yeah, very helpful.
Yeah. You guys
No.
ever think of anything? Just knock on the door. We're always here 24 hours a day.
Yeah. Now that bar can move, correct? Now I
Yeah.
know that it's usually positioned so that everything's going downward.
Yeah.
Okay.
We just, I mean, if this is the page, well, I guess I should do it this way. I mean, this part is fine to have a little peak, but then as long, because that way, if they are in a heated system, the water will bow in the lowest point. So then we can just tip it back versus it being like this. Because
In
then
which
all the
case,
water
then they
will
end up-
drain to the ET
Patient.
tube or the trach and then it can cause some
So then when we're doing range of motion, that can sometimes be in the way of
Mhm.
their one arm. Is there a better way to move it or
You
just
can
bring the
take
tubes
it,
off of it?
yeah, you could just take them out and just kind of put them on their chest even. And
Okay.
just, as long as it's not pulling at the tube or the trach, you can take, because sometimes this arm is hard to maneuver in the exact spot you want. Because it's like this way, you can technically move this part too. But if it's easier for you, like I know when I move patients, I just take this totally out and set it so I have lots of slack, so I have all of this before.
That'll make things easier.
Yeah.
So you could just take it, put it on their chest, and then they can do whatever with their hands.
And
or
then
legs.
it's still set up in a good spot for putting it back on.
Yeah, because there's still like that bow, and usually the patients are higher than this, but there's still that bow.
Mhm.
And for the length of therapy, you won't get that much rain out. It's more long-term, like you don't want it constantly dripping, you want a bowl in your circuit.
I like that idea. Take it off though.
Like when we like boost and move and turn, I always just take it off, because I find like this can be more of a hindrance than helpful, even though I'm sure that's not how it was designed. Sometimes it's almost like someone's holding your circuit back from you.
Okay.
Well, if you guys think of anything else, you can knock on our door, shoot me an email, whatever.
Okay, sounds good. Thank you so much for your
Thanks.
time.
Thanks a
Yeah.
lot.
I appreciate it.
Yeah, like I said, I think this is all just a step forward towards the bigger picture of
Early mobilization.
revisiting the whole early mobilization.
Yeah, that'll be fun. I think
Yeah.
that's exciting. I think there's already like many hospitals working towards and doing that.
Yeah.
Especially on like the high flow systems, like I see like patients moving down the hall on like the vapotherms.
Mm-hmm.
And like in places that can do it. Maybe we need to look into that here.
Well, yes, having all of the right equipment is certainly a key.